Morning, everybody. Good morning, everybody. Welcome to our meeting around the revision to private duty nursing rules that actually pertain mostly to our new initiatives. I'm going to give folks just one more minute to hop in. I still see people joining in the room, and then we will get started. All right. Good morning, everybody, and welcome. Thank you so much for joining us today. My name is Candace Bailey, and I am the HCPF Division Director. And it is our revision to private duty nursing rule stakeholder review meeting. That was a mouthful for me to say. We're so happy to have you today, May 26th and almost June of 2026, which is crazy. Happy graduation season to all of those who will have some graduates that they're celebrating. We are going to go ahead and get started. Today is really a high-level overview of a couple of our new initiatives that are coming, a couple of minor clarification things that we're looking to do with the regulations at the same time. It is really our opportunity to seek feedback from you all as we are moving forward with some of these new initiatives. So next slide, please. All right. So, as always, we like to ground ourselves in our mission as we begin, which is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide, please. Okay, so here are our objectives today. So these are the things that we are aiming for. We really want to go through the revisions to the rule, operate or highlight any operational and policy changes. So there will be some operational and some policy changes that we are proposing. Identify the impacts for everybody and really gather the feedback and implementation considerations. One of the key things that I want everybody to know out the gate here is these policies are not finalized. We need you all to help us finalize these policies. We need you all to get us to the place where things will be finalized and we can move forward. These are some new initiatives that have a lot of things to work out in order for us to get to the finalization of the policies themselves. And so this is key, and this is what we need you all to help us do, is to get to that point. Next slide, please. So here's our agenda. So we'll go through some real quick high-level housekeeping overview of our goals. I'll do a super high-level summary of the major changes, review the updated language. We'll talk a little bit about the initiatives, the acute PDN and the per diem for PDN. We'll have a discussion, and then we'll go through the timeline and next steps, all in less than 57 minutes. We got this. Next slide, please. Okay, housekeeping, super high level, pretty traditional. Let's keep the feedback specific to the rule language that we are discussing. The meeting is intended to be a verbal discussion, and so we're hoping that some folks will be wanting to speak up and provide some feedback, ideas, questions, things like that. If you prefer not to speak, or if we run out of time, which is a possibility here for sure, then we will continue, obviously, to continue accepting written feedback. We have a feedback form that folks will post in the chat here for everybody to go ahead and grab. This is not the only time to provide feedback. Again, this is our time to begin working towards a finalized policy based off of the feedback we receive. And so again, please fill out the feedback form there. Thank you, Christine, for posting that. If you are speaking, please make sure you do not share any protected health information. We are looking to post this. Please mind your e-manners, meaning don't interrupt other people. And keep yourself muted when you're not talking, respect everybody else's time, things like that. And yes, these slides will be posted on our Medicaid Sustainability and Colorado's LTSS system website. Next slide, please. Okay, so why are we even doing this? Why are we revising the rule? So really what we're looking to do is it's really expanding access to care, increasing some flexibilities, and modernizing the reimbursement while also maintaining the program integrity. It's really about making things easier to access and work a little bit more fluidly for everyone. It adds a balanced or a blended, sorry, balanced also, but a blended per diem rate option for RN, LPN, and CNA services. It creates an acute PDN benefit, much like our long-term home health acute benefit for short-term medical needs and transitions of care. And then some updates to some technical language and removing some outdated references without actual policy change. Next slide, please. All right, so summary of the major changes. So again, as I mentioned earlier, super high level summary. But what we are looking to do is removal of the skilled care acuity assessment references, adding protective oversight definition and limitations. That is something that has been referenced often throughout the limitations, and we really want to make sure that it's clear. Expanding the medical necessity and documentation standards, so really helping provider agencies understand what the documentation standards are in order to submit the prior authorization request. It creates a new private duty nursing per diem reimbursement methodology and a new acute PDN section of the regulations. Next slide, please. Okay, additional overview here. Really, we're going to be deleting the references to the nurse assessor vendor. As you all know, that program ended at the end of the 2025 year. So I think the actual date was officially December 29th, something along those lines, or maybe it's the 19th. I don't remember exactly the date, but that was when the program completely ended. We terminated the contract with the vendor. And so we now need to remove all that language from the regulation. Adding a definition for protective oversight. Protective oversight is not a reimbursable service for private duty nursing. And so we want to make sure that is clear as to what that means. Clarifying the CNA scope and custodial or standby care exclusions and duplicative service limits. Adding requirements that medical necessity support be included in PAR submissions. So making it clear that the medical necessity supports and what must be submitted to show that support. Also adding in that members and caregivers may review PAR documentation. It is updating the utilization review contractor, which is URC right there, timeline, reducing it from 10 business days to 7. That is a Centers for Medicare and Medicaid federal regulation that has been amended. So we have to adjust that here within our regulations. And then just correcting some basic formatting errors. So some basic things there. Next slide, please. All right. So now we're going to get into the meat of some of the new initiatives. So there are 2 new initiatives that we are going to cover. These were both submitted to the General Assembly, the Joint Budget Committee for budget requests. That is part of the process that the department has to go through in order to create any new initiative. The General Assembly voted to approve these, and these are now in the long bill as approved actions that the department must move forward with. Exactly how we move forward with it like to a T, is something that we get to figure out together. So the first of those 2 initiatives is acute PDN, acute private duty nursing. And what this actually does is this creates a pathway to be able to provide acute private duty nursing services. It'll be framed, and the idea is for it to look as close to the acute long-term home health benefit as possible. So no prior authorization is required. It's for acute conditions or institutional transitions. So for those agencies that really work hard to get an individual out of a hospital into their home, but there's a lot of paperwork and a lot of things that have to happen in order to get that prior authorization approved prior to bringing somebody home. Those transitions will actually be able to happen prior to the prior authorization being approved in order to help expedite those transitions when a member is ready to go home. It will be limited to 1 short-term episode each year, so annually. That is 60 consecutive days. So an episode is 60 days. It requires documentation of the acute need. And then, so it could also be a transition from a lower level to a higher level care for an acute period of time. And then after that, the transition must either go back down to that lower level of care, or an updated prior authorization request must be submitted and authorized in order for those services to maintain at that level. And then all the services, much like with acute long-term home health, are subject to retrospective review, meaning everything has to be documented and justified in order for it to be found appropriate. So next slide, please. Okay, So before I jump into this next one, I do want to just note, I'm going to run through the slides and then there will be plenty of time to ask questions and to talk about things as we go forward. I just want everybody to know that we are not just skipping each section. I just wanted to run through the slides, give you guys the baseline of the information of these initiatives, and then we really want to make sure that we have a lot of engagement and discussion. Okay, so the next initiative that we're going to discuss is probably I know it is the more complicated. It's a bigger deal and it's a big adjustment and it's a really big, cool idea that we're hopeful can be really helpful for a lot of individuals and provider agencies. So this is a PDN per diem. What this does is this establishes a single blended per diem rate for nursing and CNA services. So instead of having the multitude of the different rates throughout the day, it would be one singular rate, one singular daily rate for all of those services that are happening that day. It replaces hourly billing when both PDN and CNA services are provided on the same day. So it has to coexist on the same day. Services are medically necessary and already PAR approved and delivered per the plan of care. This is really intended to be a way to support flexible staffing mix based on member needs. And so we'll go through some examples to help kind of outline what this looks like, because it's hard to see how conceptually how it would translate into the real world. And so we're going to walk through some examples as well. And it is one daily payment that covers all qualifying PDN and CNA services provided that day. So next slide, please. We'll go into some more details because I know already some of the questions that are coming up. So the per diem does not apply when authorized PDN services do not meet a minimum threshold. So there must be at least a minimum number of authorized PDN hours in order for the per diem to apply. Otherwise, traditional billing would remain the same. Or also does not apply when there's no CNA services that day. Or when things are duplicative of another. So if they're covering the same thing, another benefit would be covering. Providers cannot bill hourly PDN and CNA units on the same day that they would bill the per diem. So it's one or the other. And then the documentation must support the medical necessity, all of the hours delivered, the CNA provision, and the plan of care compliance. And then claims are going to be subject to audit and review. That's just like for all of our benefits and all of our services. Next slide, please. Okay, before I jump into the scenario example, one of the things that I have already been asked several times from folks is around, is the hourly going away? Is it just going to be the per diem? And I just want to set the stage before like I walk into these examples of helping folks understand how this could actually work in the real world. The hourly PDN service is not going away. And so this is really truly meant to be for those members that have a mix of CNA and PDN needs. It is not really going to be for those members that have 16 hours a day of PDN. That is not going to work for this. This is really meant to be for the complex, but not as medically complex, where you have a mix of the care, because some of the things are nursing level, but a lot of the things are not. And it's really meant to be able to provide the flexibility for the staffing between the two. For those members that are much more medically complex that require that round-the-clock care, they're going to stick with the hourly rate and the hourly PDN billing. So it is not going away. It is essentially going to be a secondary option for those that have the mix and match of the two services. Not mix and match, because you can't really replace one for the other. But point being, the higher level is not going away. Okay, so let's walk through this example for everybody to see how this could potentially work. So we have a medically fragile child named Susie who lives at home with their parents, and those parents serve as the primary caregivers. They are the nurse and the CNA. So we've got caregiver 1 is the nurse, caregiver 2 is the CNA. So the two primary caregivers are the parents, And Susie requires daily skilled nursing for respiratory treatments, medication administration, and monitoring of chronic health needs. Also in the home is Tommy, who is also a medically fragile child that is receiving in-home private duty nursing services for non-invasive ventilator care, medication administration, and ADLs. So you can see these are Susie's authorized service hours and Tommy's authorized service hours. There is a mix of each, as you can see from this list here. Next slide, please. Okay, so here is the example of a quick little run through of how the care is provided. There's, the morning, afternoon, the evening, and then throughout the days with the various cares that are being provided to the individuals. And that includes, the big thing here to keep in mind is that includes things like activities of daily living, and then routine care needs such as G-tube feeding, assistance with bathing, feeding support, things like that. Next slide, please. All right. So with the per diem for this particular household, the care team can actually be much more flexible and responsive to Susie and Tommy's changing daily needs. So the nurse and the CNA services can be coordinated throughout the day based on real-time care demands. It really allows for much smoother transitions between the skilled nursing and the personal care support. So instead of having the nurse providing the activities of daily living, which is a task that should be performed by a CNA, they can easily flex between the two services without having to worry about the scheduling of the nurse versus the CNA on the fly and not having to do it 6 months in advance. Families caring for multiple medically fragile children can better manage overlapping care needs, so it'll make it easier for the nurse to go from one to the next individual and the CNA to kind of plug in there in between. It supports a more person-centered approach that aligns the care delivery with the family routines and member needs. And it really increases the continuity of care and reduces the disruption for members throughout the day. Next slide, please. Okay, so without the per diem, so just to kind of show you that was with and then without the per diem, the nursing CNA services are scheduled and they're in very separate fixed shifts. So instead of being a little bit more fluid in what they're able to do, they are in fixed shifts. The CNA is from 8 to 10 for Tommy. The CNA is from, 12 to 2 for Susie. It really allows a little bit more flexibility with that. The care is delivered based on assigned task blocks rather than changing daily needs. The flexibility is very, very limited to adjust when one child's care needs increase unexpectedly. Caregivers may need to coordinate multiple schedules, and then there's just less opportunity for coordinated support across both members in the home. Next slide, please. All right, so here are some overarching benefits for the per diem aspect of having the blended rate. So one rate for the entirety of the day for all of the care needs. It really supports members remaining in their home and communities and encourages much more coordinated whole person care throughout the day. It improves the continuity of care by allowing services to better align with changing daily needs. We know that a lot of individuals, based off of, the temperature, there's a number of things that can change a child or an individual's care needs. And this really allows for that flexibility and that fluidity of those changes to happen during the day without having the pre-scheduled aspects of the care. Helps reduce disruptions. It supports family caregivers by supplementing complex daily care needs, promotes a care model that is integrated, and it maintains focus on the medically necessary person-centered care while also preserving existing medical necessity standards. So next slide, please. All right, and some operational benefits of the per diem. It provides a more flexible mix of the RN and CNA services based on the member's care needs, helps providers adjust staffing more easily. So if there's multiple children in a home, for example, the agency can schedule the nurse to be at the home for 10 hours, let's say. And then they can have a nurse or CNA there, and they can work between each other back and forth based on the needs of each individual child. And it just allows a little bit more fluidity between the different children there. Um, Reduces the administrative burden associated with separate billing hours, which is super helpful. Instead of billing, 2 hours here, 2 hours here, an hour and a half here, it is much more of one daily rate. And that's it. Encourages the coordinated delivery of nursing care and personal care services, and it doesn't change the medical necessity requirements at all or reduce the authorized levels of care. None of that changes. All of that remains. The idea is just to make the staffing and the scheduling much more flexible for everybody. All right, next slide, please. Okay, so here is the fun part where we are asking for feedback. So what we want to understand is we want you all to ask questions. I want you to, this is a brand new concept that is going to take us all a while to get to a place where it is going to be a finalized policy. So ask questions, help us understand what is going to be necessary. How is this going to work? Where do you foresee some pitfalls? Are there unintended impacts to the continuity of care? What implementation supports or guidance would be helpful? Things like that. And so I have folks on the line that are going to help me, they're going to help facilitate the questions that are coming in and everything like that. So I am going to ask, who is monitoring? Do we want to start with hands raised? I see we have one hand raised, or do we want to go with questions? Christine?
Let's go with the questions, the hands raised.
Okay.
And first we have up is Jack Robinson.
Hi,
Hi.
Jack.
Hey, how are you?
I'm great. How are you doing today?
Good. I just want to make a comment about the per diem rule
Sure.
change. I know the department has repeatedly stated that this proposal didn't alter medical necessity determinations or reduce authorization levels of care, but that framing overlooks the practical reality that reimbursement structures drive service delivery. Under the proposed blended per diem methodology, providers receive a single reimbursement amount regardless of the actual mix of RN, LPN, and CNA staffing. The unavoidable economic incentive created by that structure is to maximize lower cost CNA staffing while reducing reliance on higher cost skilled nursing care. Whenever possible, over time, that financial pressure will inevitably influence staffing practices, provider participation, utilization review decisions, and family expectations regarding what level of nursing care is considered appropriate in the home setting. And that's my concern is that practical matter, this
Yeah.
proposal risks reducing actual access to PDN for medically fragile children. And providers are already struggling with their margin staffing shortages and administrative burdens, and this is going to further complicate that.
Yeah, for sure. And I appreciate that, Jack, and understand. And that is the natural place that most people go, well, this is going to make it harder, and agencies are going to take advantage so they can receive the highest profit margin. I will just say that agencies are still required to make sure that all of their staff operate within their scope of practice. So they cannot delegate care that cannot be delegated to a CNA. Like that is against all sorts of licensure standards for the agency, for the nurse, for all of the people. And so those requirements and those levels of appropriate scope of practice, appropriate care levels remain. That doesn't change with this. What this does is it allows these agencies, which I will tell you, the majority of them in good faith really want to make sure the members get the care that they need, and it helps with the scheduling. It is really going to be most beneficial for those with multiple children or adults in the home. That is where I think the flexibility is going to come in handy the most for folks. But it absolutely doesn't change whether or not what standards are held to. And again, they cannot delegate non-delegatable tasks to a CNA, like things that is outside the scope of practice, absolutely cannot happen, and they will be held accountable, and all the way down to the individual, which I will tell you, most nurses are really cautious about delegating tasks because of that.
Which is real quick, and I don't mean to, well, just pushing back on that. I mean, probably as you know, I've done probably more than, I don't know, 40, 50 PDN appeals, right? And I think we all know that the scope of practice for a CNA is vastly expanding over time. so much different than it was without even really rule changes or Nurse Practices Act or whatever. It seems like, in my experience anyway, in doing these, that the role of a PDN is really being eliminated in a lot of respects. Whether it's health maintenance activities or certainly that CNA and CNA with a med add-on or whatever, that really the driving force here is to eliminate all PDN and replace it with CNA. So
Yeah,
that's my
that's
practical,
yeah,
cynical outlook on things.
fair. And it's absolutely not replacing PDN. That's not feasible. There are always changes within all fields, as advancements are made and things like that. That's just how it works. And so absolutely the CNA scope is changing and evolving as all of the medical field is, and that's just the natural way of how things work as you make more discoveries, more training, things like that. So I hear you, and I would respectfully disagree that PDN is being replaced by CNA. All right. Next hand.
We have Catherine Morrison.
Great. Thank you. Hi, Catherine. Welcome.
Hello, Candace. Thank you for going through this. I did have questions. I didn't realize I raised my hand. So let's go. Let me go. And I'm sorry if I missed this, but it's always good to clarify. So when the PDN services do not meet a minimum threshold, otherwise traditional building will apply. What is the threshold?
So we are working on that and really hoping that everybody can help us with that framework, right? So what is the minimum threshold? Obviously it has to make sense that it can't be so low that the per diem ends up breaking the budget, right? We can't pay more for the services than we already are paying. And so we have to be careful and mindful of that. Right now we're looking at, because PDN is continuous in that in general is more than 2.5 hours continuous care. So we're looking at, I think 3 to 4 hours as the minimum. But again, we're hoping that you all can provide feedback to help us determine what those thresholds should be. But none of that is set yet. That is the goal of these engagement opportunities, is for you all to help us finalize the policy in a way that makes sense.
Okay, great. Thank you. And then you said this is truly meant to be a mix for members who have a mix of CNA and PDN needs. So when Susie or Tommy are getting approved, is it going to be based on past staffing? Like Susie has previously had a CNA and a PDN, and so then she qualifies? Who determines that there's an appropriate mix of CNA and PDN needs?
Right. So the request of the medical necessity review process for both PDN which is nursing, and CNA needs remains, right? So the full picture has to be presented to our vendor that is doing the medical necessity determination to determine, yes, this individual has both levels of care needs that should be outlined in a plan of care. And anytime, especially if there are two agencies in the mix, those plans of care and those agencies should be communicating. It's actually required by license, should be communicating and working together. And so those plans of care and those requests would come in as one, so that the vendor could review them as a whole.
Okay. That's all I got right now, but thank you. Yeah, appreciate it.
Thank you so much, Catherine. I appreciate it.
Our next hand raised is Megan Bowser.
Hi, Megan.
Hello. I still have all sorts of questions about the per diem piece, but I'm going to focus on my questions on the acute piece because those are both involved, and I feel like I can articulate those better. I guess my one feedback on the acute is particularly around the 1 episode per 12-month period. I think that's great in this theoretical place, but I think there could be a better way of capturing the actual need of likely the most complex kids or adults that need PDN are often also likely to have multiple acute periods. Like, let's say they get a respiratory virus in January and have a whole bunch of extra supports for a month or so after they get home. And then they have a massive surgery in September and have a whole bunch of supports after that, right? That's not a gaming of the system in order to get the acute. These individuals will often have multiple acute episodes in a year. And so I think there's better ways than saying just 1 per year period to put some regulations like you can't have back to back, or it has to be a separate hospitalization or some other way to capture that rather than just assuming only one acute thing happens every
Okay,
year.
that's super helpful feedback, and something that we can look into around how that would work and what that would look like, what language we could use, or yeah, that's helpful. Thank you for that.
Yep. And the per diem, I don't know. I get the concept of it, and I'm still not sold that it'll actually function in a usable way for members in the real world.
Okay. Yeah. Appreciate that, and that's fair feedback, Megan. Thank you. All right. Do we have any questions that have come into the
We
chat?
do. We have a couple in the chat. We have they're both from Kristen Waldrop.
Okay.
The first one is, what is the HCPF definition of per diem? And is there a regulatory citation? And
So we're
then,
working on that right now. Around the per diem and what that would look like. That would go into the regulations. And so all of that is being developed as we speak. Per diem is usually per 24-hour period from, 12 a.m. to 11:59 p.m. or something along those lines. But those are usually pretty well defined. And then, sorry, I see the other question too, Christine, so I'll just read that one too. What if PDN and CNA are different agencies? So that's where I was getting into. They'll have to coordinate the care. It'll be very similar to the way that CNA services are provided under the Developmental Disabilities Residential Services, where the agency contracts for the CNA. So it'd be very similar. It would have to be one prior authorization. And then if we have a private duty nursing agency that doesn't provide CNA, then they would contract with the current agency that does, so that it could be really coordinated care and it has the one authorization. All right, do we want to go back to hands?
sure, next one is Molly Wiley.
Hi, Molly.
Hi, good morning.
Good morning.
For the per diem, is the option or the requirement for using the per diem, is it based on authorization, or I've seen in some of maybe in the verbiage in the draft about what's received. So for example, let's say on Wednesday, staffing looks like this, but it's less than what's authorized. Is it possible that the per diem is billed one day, but then maybe the next, because what's actually received, the staffing is a little different, then it's billed hourly? Is it flexible in that way based on staffing, or what the actual par is?
That is a great question, and I don't have the answer for that, but that is something for us to take back and think about.
All right. Thank you.
Thank you. Thanks, Molly.
Sure thing.
It looks like Catherine Morrison's hand is raised again, but there's two of them.
So something
Catherine,
seems
how
to be
many of you are
happening.
there?
There should only be one that I'm aware of that works on my team. This is Veronica Charles, who also works with Catherine Morrison at Maxim. And
Oh, funny.
I've decided to be Kate today. I'm so sorry. It's confusing for me, and I'm sure it's very confusing for you all.
If she registered and you used her link, that would be why it would show up as her twice.
Perfect. Well, I'll be Catherine. She's Kate.
Perfect.
Veronica Charles with Maxim. Thank you so much, Candace. It is always truly a pleasure to work with HCPF. We appreciate all that you guys are doing. We do have some concerns that have already been echoed by some of our colleagues. One of the things that I wanted to hop in on was Megan's comments regarding acute PDN.
Okay.
I think that will be really helpful to take those concerns back, just regarding that some of these individuals, if they are likely to receive acute PDN after a hospitalization, they are more likely to receive that multiple times in a year. So for various surgeries or whatnot. And then the only other thing that I'll add in there is that frequently we implement a transition team to be able to bring those individuals back into the home. And so that requires a lot of RN hours. And so that acute time is very helpful, because even if the scope might be lower in an LPN per se, having an RN able to navigate that care team in the hospital and in the home is really needed while they come back into the home after a hospital stay. And that does not change even if this is unfortunately normal for that individual. They still will require that individualized care with an RN because of the different physicians that they'd be seeing from different surgeries or whatever that may be. So that piece is going to be really helpful. I actually think that this is a really great policy proposal if done right. I think I understand why you guys did it one time per year because we don't want to incentivize hospitalizations.
Right.
We want to reduce hospitalizations, but if they are needed, we want to make sure that we're able to help fully get that individual home with additional financing. So I do think that that is helpful, but I recognize kind of the tough position that you are all in to make sure that we are not encouraging hospitalizations, but also helping those that do have those acute times.
Yeah, that's super helpful. Thank you, Veronica slash Catherine. Appreciate that feedback. It's, not incentivizing hospitalizations, but also not completely negating an agency's responsibility to have the services prior authorized. So there is a balance there. But I hear what you and Megan are saying, and I think that is really valid feedback and something that we will absolutely take back and see how we can work on that.
That's helpful. That's helpful. And then the last comment was just regarding the per diem piece, of course. We do have some of the concerns echoed by Jack. I recognize that the state's intent is most certainly not to make sure that this supplants PDN. It is just a supplement. We completely agree with that. One of the things that I just wanted to flag for you, though, that even if, again, something might be within an LPN's or an LPN scope, maybe not a CNA per se, is that usually when there's a staffing shortage, that's really when we need to implement our registered nurses. And so we would be required to use somebody like maybe a supervisor because when we're still experiencing the shortage that we are right now, we're going to look through whoever we have that handles more of a caseload, and so we would still be trying to utilize RNs in cases of extreme shortages and still not be able to have that reimbursement with the PDN with the per diem model the same way that we would be if we're just billing based off of the scope of practice or based off of the individual providing the service. This was actually a regulation in Maryland. I'm sure that you guys probably came across that in your research, and it was actually overturned this year. Just not necessarily at the per diem model. The per diem we really see in Indiana, maxims in 42 states, as you guys know. So we've seen this a couple different ways. But in Maryland, they just recently in this legislative cycle pulled out the requirement that they are paid at the same level based off of whatever their equivalent of the PAR says. So whether if you need a CNA, you get reimbursed at a CNA model, even if you throw an RN into the home. And so they said it doesn't matter whatever the qualifications are, you're going to be reimbursed based off of what we have put on the authorization that you would require. But they did find a lot of difficulties with that over the years. And so I think that there's some good public comment that we'd be happy to forward your all way, just so you guys could see that, because that was a concern in the state.
Yeah, I think that would be super helpful for us to see kind of how they had it built, and to better understand that. Yeah, if you don't mind sending that, that'd be great. And
Perfect.
then would you say Indiana also?
Indiana does have the per diem. Yes, Indiana has per diem. I hate to say it, but their reimbursement rates also are double what Colorado's are for PDN. And so the per diem was helpful because it was on top of, closer to a $70 an hour reimbursement rate, just the public fee for service rate. And so that was helpful with things like, they have a new value-based reporting model where providers
Mhm.
were now taking additional data, reporting it back to the state. They got a lot of nice, innovative things out of the per diem. But I do think that that was just in addition to rates that are a little bit more tolerable than the state of Colorado, unfortunately.
Yeah, there. Okay, that's helpful. Thank you so much for that information
Thank
and
you,
your
Candace. We'll
willingness
get
to
that over
share.
to you, and anything else that we find, we'll send your
Okay,
way.
perfect. Thank you so much. It's great.
And now
Okay.
we have the actual Kate Morrison.
Kate, is your hand up again?
Sorry, and yes, it is. I just wanted to say on the acute period, I was going to echo everything that was said. Veronica's going to send over some materials. We discussed this with other states. I have some examples that you can pull from. I'm
Great.
thinking about Utah and Texas, what qualifies as that kind of acute event. So I'll just add that into what Veronica's sending you.
Awesome. That's super helpful. Thank you so much.
And our next is Matt Calusi.
Hi, Matt.
Hi, Candace. How are you?
Excellent. How are you?
Good. I just have more of a technical question. I was
Okay.
curious how far down the road you guys were with discussions with CMS I'm particularly curious about, the way that the description of private duty nursing flows down from the Social Security Act through the CFR is being limited to LPN and RN. And I'm just curious how far you are in those discussions with them and if they've indicated approval of adding CNA in.
So we have not had the discussions because we don't have the policy finalized to share with them yet. And so what may happen, Matt, to your point around their calling it PDN, there may have to be some sort of like change in the name. Instead of PDN per diem, it might be, skilled care per diem or something along those lines. But no, we have not proposed this policy to them because we're still so in flux with the finalization of it.
Okay, thank you.
Yeah. All right, next hand.
No, well, I just got a Kelly Panetta.
Panetta, pretty close.
Sorry.
Hi, everybody.
Kelly.
I see one of your bullet points is our documentation expectations clear. So I pulled up the, draft rules, and I guess I'm a consultant, not a provider, but under 8.5409E, I don't have a clear understanding of, versus like shift documentation. It says providers shall document the total number of PDN hours delivered per day, provision in the provision of CNA services on the same date. I just can't kind of wrap my head around what that would look like. Just so to me, it's not clear, but you know what? It might be to the provider agencies, but I want to be able to support our agencies. So
Yeah, so I mean, the documentation around that would be, very similar to what it is now. It just would be for the entirety of the day. Right now, one of the common practices is nursing notes, documenting each assessment that is performed, things like that. And it would be making it clear that, there was 4 hours provided on this day, 6 hours provided on that day, and then the tasks that were provided from the plan of care. And so I think if there is more clarification needed around there, we would ask providers to provide us some feedback on like different ways that we could word it. That would be helpful.
yeah, so like it wouldn't have a time in, time out kind of thing because it's not a shift. Maybe I just need to see some examples, but yes, I just wanted to, get a little more clarification on that. All right. Well, thanks, Candace. I appreciate it.
Of course, of course. Any other questions from anybody? Anybody, Christine, that has their hand up?
No hands and no new questions
Okay.
in the Q&A. So
Well, let's go to our timeline next, and then I can kind of talk about next steps after that for folks. This is a lot, and it's kind of new. I know most of you are aware of these initiatives coming out, but this is our first time that we've really been able to talk about it bigger picture with everybody. And so sometimes it takes a little bit to think through all the things that we've said and come up with additional questions. So here is our general timeline. So we put out the draft rule for everybody to take a look at. Again, draft. The expectation is that these are going to change quite a bit. The expectation is that you all will provide us feedback so that we can make adjustments so that these can be operational in the real world and things that you all can actually utilize. We have, our stakeholder review. Our plan is to make updates based off of the feedback that we have received today, and then other days as the feedback form is still out there. We are hoping folks will continue to submit it. We will have a second draft back out by June 15th. We are going to then, and quite frankly, we can make additional changes between June 15th and the initial adoption. So our plan is to take this to the Medical Services Board in September for a final adoption in October, for the effective date to be in January. And the reason why that is so early is because the way that the calendar falls for the Medical Services Board, the month of November, I believe, there was actual no final there's no rule effective dates in that. And then December with the holidays and the joint budget committee hearings and things, we try to steer clear of that so that everybody can put their time and attention on those areas. And so that's why this is looking to come in September, and what feels a little early for a January effective date, but that is the plan there. Next slide, please. Okay, so next steps and feedback. So really, this is our initial step, right? Our initial step is to open these conversations, talk to you all, put it in front of you, get the concepts out there so you all can start thinking about it, providing the feedback, I love, Maxim, thank you so much for being willing to provide things that worked in other states or didn't work in other states. It's really helpful for us. So you can review the rule draft in its entirety on the Medicaid Sustainability webpage. We will, as I noted, we will be posting a revised version of that in the next couple of weeks. Please continue to provide suggestions to improve the language, make it more clear. By June 8th, we'll take all of that, put a second draft out. Again, that is just the second draft. We anticipate continuing to receive feedback and make changes from there. There's the feedback form. If somebody could post that again for me, for folks that weren't on earlier, you can fill that out for us. Or feel free to, send any emails with questions or comments to the home health inbox. It's pretty difficult. It's homehealth@state.co.us. We're happy to continue to engage and have these conversations. It's really, really helpful for us to make sure that we can get to a good finalized policy. And then please make sure you stay informed by accessing all the resources that are linked in this slide deck and sign up for our newsletter. It's really exciting. We have a team dedicated to that provides really great updates with useful helps, links and tips and tricks and all the things for everybody. Thank you for Christine for posting all of the links and all of the things there. And then we'll go to the next two slides for now, because the next one is questions, but we already covered a bunch of questions. Any last minute hands up by any means? Or any last minute questions that have come in? Matt, I see your hand.
Real quick, I forgot to say that thank you. We do support the acute episode for sure.
Awesome.
But also echo my colleagues' concerns with having a limitation of once per calendar year. That might be problematic. But again, thank you.
Thanks, Matt. I appreciate that. That's helpful.
Sure.
Any other last minute comments, or you guys will miraculously on a private duty nursing meeting get 13 minutes back? All right. Again, please continue to submit your feedback. We cannot move forward without the feedback from you all. We need you and your partnership at the table here to be able to move all this forward. But really want to thank you for taking the time on the day after Memorial Day. So sorry about that. To come and join us and listen to me talk for 47 minutes straight, because I'm sure that was super exciting for everybody. I appreciate you all, and I hope you have a wonderful rest of your day.
Thank you.
Thanks all.